Dr. Naseem. For those who don't know me, I see the faces, the majority, I know the majority of you guys. We'll talk today about DKA. So the way we'll do it, we'll split it between me and Dr. Shaima. What about now? Now it's better?
Yeah.
Okay. So we'll split the talk between me and Dr. Shaima. The purpose is to, my first part will be just to give you background about the clinical part of DKA, like clinical presentation, how the patient comes, what's the typical labs, how do we make the diagnosis of DKA, and then Dr. Shaima will focus mainly on how we typically write the orders, like the things on the order sheet, okay? To start with, what's the criteria of diagnosing diabetes? This is not DKA, diabetes. We talk about random blood glucose more than 200 milligram per deciliter, fasting glucose more than 126 milligram per deciliter or 7 millimole, and 2-hour glucose tolerance test. We look at the 2 hours PG, and it should be above 200 to make the diagnosis of DKA. Most of our patients, we make the diagnosis based on A1C. Why? Because A1C is easy to be done, and also it's a fast test, doesn't require fasting. You can just send the patient to the lab and get the result within 15 minutes to 2 hours, depends on your lab. So if the A1C is more than 6.5%, it's diabetes by definition. Majority of our patients got admitted a few hours. If it's not few minutes after making the diagnosis of diabetes, they come to the clinic with symptoms. We check the A1C. We know that they are diabetic. They got the shot from us, and they come to you guys within 30 minutes. Pre-diabetes is the new entity. If the A1C is more than 5.7%, invert fasting glucose. So if the fasting glucose, we mean by fasting 8 to 10 hours of fast, then we check the glucose. If it's more than 100, it's pre-diabetes. And invert glucose tolerance if the 2 hours plasma glucose is 140 to 199. Those patients, we typically treat them, but not with insulin, with oral hypoglycemic agents. All right, let's go ahead and talk about symptoms of diabetes. The majority of you know that typical symptom of diabetes is polyuria, which means the patient pee too much. Polyphagia, they drink a lot of water. Polydipsia, they drink a lot of water. Polyphagia, they eat too much. The main symptoms is general malaise, headache, weakness, irritability, weight loss mainly due to insulin deficiency. The body cells cannot utilize the glucose because they're lacking the insulin, and the insulin is the key that let the glucose go inside the cells. So if the key is missing, the glucose will be trapped in the blood, in the circulation, and the cells doesn't have any source of energy, so they go into starvation mode, which leads to breaking down of protein because they don't have glucose, so they utilize the body protein, and then they break down the fat, so the patients typically lose weight before they get diagnosed. Once they get the insulin, due secondary to the injections, they start to utilize the glucose, so the glucose goes to the cells and they start to gain weight. For pediatrics, sometimes they have failure to fly, but the majority doesn't reach to that point. All right, what about DKA? So the patient typically presents with severe dehydration, dry lips, dry mucous membrane, they cause a lot of tears, very concentrated. Typically, the urine is in dehydration. The urine is usually concentrated, but in DKA, because of the hyperglycemia, the kidneys trying to watch out the glucose, so they pee too much water with the glucose. They tend to have acidotic smells. So I advise you guys, when you see a patient with DKA, try to smell his breath, so you will know what's the acidotic smell. Feel nice. And then abdominal pain. Typically, because of the acidosis, will lead to gastric irritation, so they get abdominal pain, vomiting. Some of them they get drowsy and coma due to, who knows? The drowsiness and coma is typically due to brain edema. We'll talk later why brain edema occur. And then specific symptoms, they could have inborn immunity, which lead to infections. So some of them they present with on diagnosis with UTI. In adult candidiasis, but in pediatric UTI, sometimes pulmonary infection, these kind of infections. On examination, we could find the patient wasted, dehydrated, decreased level of consciousness. Some of them become comatose. Wasting and dehydration will present like the patient, you find the patient is tachycardic due to the dehydration. Some of them, they get to severe dehydration stage, so they get hypotensive, and they typically are tachypneic because they are acidotic, and the way of the body to wash out the acid is through breathing and through kidneys. So they breathe fast, drop it and deep breathing, trying to wash out the acids. So they are typically tachypneic, and they have what we call Cosmic breathing. Cosmic breathing is deep, rapid breathing. It's like, this is very typical breathing for patients with DKA, okay? In terms of other features of physical examination, we typically assess growth for all children, but the family will let you, if the family has a documented weight before, you will see that the patient lost about, depends on his weight, but about 5 to 10 kilos. If the patient has pre-existing diabetes, because DKA could occur at the first onset of diabetes, or for patients with pre-existing diabetes if they are not compliant to their medication. If they got any source of infection, any source of stress on their body could lead to the development of DKA. If they are not compliant with their medication, so they are always having hyperglycemia. I can give you example from the patients in the world, but the last 3 admitted patients, one of them, she always have blood glucose in the range of 200 to 150, which is really high. And then the dad was very surprised why she developed DKA. So long-standing poor control will lead to DKA. Missing injection will lead to DKA. Specifically basal injections. Latifa talked to you about the types of insulin. So the basal insulin is protection from DKA. If the patient missed the basal insulin for 1 day, they could immediately develop DKA. Okay? Some of the patient has what we call lipohypertrophy. I suggest to you guys, when the patient comes, when you examine, check the injection site. If you find lumps on the injection site, it means lipohypertrophy. What does that mean? The patient is abusing the site. He's injecting all the time on the same site. So this site is not anymore absorbing insulin. So the patient gets insulin there, they are getting their full dose in the right time, everything is good. However, the insulin is trapped here. It doesn't get absorbed to the circulation. And this could cause DKA. So always check the injection site. If there's lump, notify us, tell us doctors there's lumps in the injection site. And we do the assessment of complication related to diabetes. If the patient has pre-existing diabetes for more than 10 years, fundoscopy examination, feet, hands, all type of complication assessment, including hypertension. So monitor blood pressure. If you notice the patient's hypertensive, let us know. Maybe we don't know on the outpatient basis. So if the patient is starting to have hypertension, this is really serious sign. Laboratory assessment for DKA. The first thing we do in the clinic, after we feel like the patient clinically looks sick, or in the ER, we send urine for ketones. This is the first and the most important sign of developing DKA, right? So the patient comes to the clinic, he looks really terrible. He has abdominal pain, he's vomiting. Typically, abdominal pain, vomiting is really serious sign. In patients with diabetes, you have to think about DKA. Do not think about gastroenteritis. It could be gastroenteritis, but the first thing you want to rule out is DKA. So we send the patient with urine deficit, and we check for urine ketones. If there is positive for ketones, it means that the patient could have DKA, or he could have pending DKA, which means he's not in acidotic now, so his body started to make ketone for sure, which is the first step of developing DKA. However, we're not sure if the acidosis reached to the cutoff of diagnosing DKA, which I'll mention later, or not. So at any case, he needs to be to get our attention. So when we check in the clinic the ketone and we find it positive, we send the patient for admission because he could be actively DKA or he will develop DKA in a few hours. Okay? And then we check for urine glucose, which is typically will be positive in patients with hyperglycemia. A1C, we do renal function test. If the patient new onset type 1 diabetic, we check for comorbidities with type 1 diabetes, which is typically hypothyroidism and celiac. This usually comes with diabetes. So always when the patient is new onset, if it's new onset, we check for the thyroid and the celiac disease. All right, in terms of management of diabetes and of DKA, it's always education, 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 and education. This is the main and major line of management, education, because DKA is fully preventable. If we have patients who receive proper education, typically they could live 30, 40 years in type 1 diabetes without single episode of DKA. We have seen multiple patients like this. And we have terrible patients, disadvantaged, unfortunate patients, who tend to develop DKA once to 3 times to 4 times per year, right? We have these patients. There's a lot of issues. Education, one of the major issues that predispose patients to DKA, lack of education, And then social, number 2. I don't know if it's here in the list or not. Social issues is number 2, really, really, really important in managing diabetes, because diabetes is a social disease, right? So if the family, there's issues, lacking of private caregiver, the kid is starting to be 11, 12, and the family is throwing everything on the kids, go get your injection, go do that and this is really not helpful. So the patients require a very attentive caregiver, whoever that caregiver is, parents or grandparents or whatever. Then they need to regular blood glucose monitoring, minimum 4 times per day, food planning, exercise, psychological support. All right, I'll give you a quick example. How much time I have? 5, 10 minutes?
You did time? Yes,
Around 10 minutes, okay. So 13 years old boy presented today with a history of vomiting abdominal pain for 1 day. Okay? This is all what the ER physician know about this patient. And this scenario is really common. They do not volunteer to tell you that the patients have heart failure. They do not volunteer to tell you that the patient has chronic kidney disease. They come to the ER and their major concern is vomiting and abdominal pain. Then it's our job to take proper history. When we take proper history, we'll ask about, does the patient have any chronic, pre-existing chronic condition? Yes or no? Does he take any medication? And then we extract the data from the family. So we don't blame the family, because a lot of the cases actually, type 1 patients goes to the ER with vomiting abdominal pain. It doesn't cross the mind of the ER physician that this patient has DKA, and they send it home. And then they come comatose to the ER. This typically happens in, I would say, to be fair, in hospitals where there is no pediatric endocrinology service, because typically if there's pediatric endocrinology, a lot of admission in ER to DKA, like the doctors will be familiar. But in the small polyclinics, in small hospitals where there is no endocrinologist there, or sometimes there's no pediatrician even, so general practitioner or family doctors, we're not judging anyone, but I'm telling you the scenarios that we typically see. A lot of patients, this scenario happens. So anyway, what's the first thing you would need to assess in ER? What are the important points to take from history in ER, and what is your differential diagnosis? These are the 3 questions that we would like to answer. So we got information about the kids, as we knew that he's 13 years old, not to have type 1 diabetes since 4 years of age, on medications. Insulin, I won't go into details because Latifa, I'm sure she covered this sometimes. About insulin. Insulin type,
Yes.
Yes. And he came to vomiting, generalized abdominal pain, hyperglycemia for 1 day. On the day of admission, his father checked his blood glucose and it was 410 milligrams per deciliter, and he started to vomit 3 times. Whitish materials, no blood, no mucus, because he wanted to keep our mind open, right? This could be any source of, could be appendicitis, right? So we have to get details of the vomiting, details of the onset of abdominal pain, the severity, the location, all these details. Anyway, positive history of polyuria, decreased activity, decreased oral decreased activity, and eating sweets, increased the amount of sweets in the last month. This could be happening in Ramadan, by the way, because typically people make sweets. And then no history of loss of consciousness, positive history of polydipsia, positive weight loss, always meeting his insulin doses, positive history of previous DKAs, no previous hypoglycemic episode, and no previous history of PSU admission. Developmental up to age socially was fine actually. So, important part of physical examination. First of all, you have to check the conscious level. Patient is oriented and alert or not. Dehydrated. He was dehydrated with mild sunken eye. Capillary rate was 2 seconds, which was fine. Palpable peripheral pulses. He had palpable peripheral pulses. And then his vitals. His CNS examination was a remarkable respiratory examination. He had cosmic breathing, but on assessment of the chest, airway was clear, which means less likely to have pneumonia actually. Cardiovascular and GS assessment was fine. Growth parameter is really important. If pre-existing diabetes for a long time with poor control, you'll find that kids are stunted, they don't grow in height. On top of being underweight, but the renal growth will be affected. This is his laboratory assessment. So typically we order CBC, we order urine and electrolyte, we order renal function, if it's separate than UND. We order bone profile, we order glucose. No need for insulin level because we know that the patient is diabetic, so we cannot utilize this data. We order urine, dipsticks. If we think that he has any source of infection, we check for that infection. If he's febrile, for example, we could check by doing functional workup, these kind of things. Okay? And here is the result of his lab. He had low phosphate, low positive ketone, +4 for ketone. Urine was +4 for ketone. He has, if you notice the hemoglobin here, he had high, the hemoglobin was a bit higher than his age 15, which is a sign of hemoconcentration. His blood is very, the water volume is low, so the hemoglobin is concentrated. Okay. A1C was 12.4, random glucose was 500 milligrams per deciliter. This is his BBG. You see the pH is 7, it should be between 7.35 to 7.45. So he is acidotic, very low pH. And then, I don't know what happens here. And then you can see the bicarb. Bicarb typically should be between 22 and 24. This bicarb is low, 5, so extremely low. So this is metabolic acidosis because the bicarb is low and he has acidosis. So how do you make the diagnosis of DKA? Hyperglycemia with metabolic acidosis with ketosis. We'll finish it?
I think we
Yes. All right. Okay. Sorry. Presentation. How do you can we make? Yes. Oops. What's that? So how do you make the diagnosis of DKA? Hyperglycemia with metabolic acidosis with ketosis. So hyperglycemia, we can check it at the bedside. Ketone, we can check the urine, and then we send it to the lab to make sure that they reach to the point of metabolic acidosis. These are the 3 elements of making the diagnosis of DKA. And then the severity of DKA depends on the pH and bicarb. Let's say if the pH is less than 7.35, bicarb less than 15, this is mild DKA. In this case, his pH was less than 7.0, bicarb less than 5 or 5. This means severe DKA, okay? So how do we manage this patient? Typically, the management is, we focus on 3 elements. First of all, the most important element is to rehydrate. However, we have to be extremely careful with how do we rehydrate. We want them to correct as slow as possible. We don't want to fix rapid fix. Rapid fix will cause us rapid changes in everything. Rapid drop in osmolality, rapid drop in glucose, rapid drop in sodium, because the blood is really concentrated. There is a little bit of water, and then we give a lot of IV fluid. Let's say we give boluses of fluid. We're diluting everything very, very quickly. When we do that, the patient will immediately develop brain edema, and they could die. And the risk of death in each admission of DKA is about 5%. So if we make the big mistake of rapid hydration, we were pushing the patient for death, right? If brain edema happened, brain get herniated and they could die. So this is why we keep the patient on neuro observation hourly in the first few hours of DKA. We monitor Glasgow scale very carefully. If you have concerns about brain edema, we typically, slow down on the management fluid rate to try to prevent the worsening of the brain edema. Sometimes it's not our fault. The patient comes with severe DKA and with brain edema before we touch the patient, but we don't want to make things worse, right? So this is number one, hydration. So we typically calculate the fluid to give them hydration in a slow rate. Number two, we want to fix the insulin deficiency by giving insulin. We cannot give sub-Q insulin. It doesn't work. It has to be insulin infusion. And Shema will talk to you about the order of insulin infusion. This is number two. So we don't really pay attention to hyperglycemia because it will be fixed with insulin infusion. Insulin infusion, the purpose of giving insulin infusion not to treat the hyperglycemia. The purpose is to wash out the acids. So once we give insulin to the body, the process of making acids, which is the fatty acid oxidation, will stop immediately. We talked earlier that the cells is in starvation mode. No insulin, no glucose coming to the cells, right? And the body is breaking down protein and fat. When the body is breaking down fat, they develop acids. This is why keto diet, they typically have acids, ketones, because the body produces acids when the patient is breaking down fat. This typically happens in keto diet. So in DKA, the production of acid is really high. This is why they develop metabolic acidosis. We want to break that by giving insulin. Once we give insulin, the acidosis will be washed and hyperglycemia will be fixed. So we treat fluid with hydration. We give insulin to treat acidosis and hyperglycemia. And the third thing, we try to correct electrolyte disturbance. If the patient has hypokalemia, we give potassium. If the patient has hyperkalemia due to prerenal failure, due to the severe dehydration, we typically monitor potassium. If the patient has hypophosphatemia, we give phosphate. So we adjust the electrolyte based on the patient's needs. Okay? This is the Cosmic breathing. This is what I was talking about. Here is the typical breathing. Here's the Cosmic breathing. Fast and rapid and deep. Fast, rapid and deep. Okay? All right. I think so. Management A, B, C, D, E. I always add G to every patient in AR because you don't wanna miss hyperglycemia, right? So any sick looking patient, we always start our management with A, B, C, D, E, and then remember G to check the glucose. The next side, and we talk about these, all of these. When do we stop insulin infusion? We stop insulin infusion when the acidosis is resolved. So typically, if the bicarb is above 18, we start to think of stopping the insulin infusion and switching patient to sub-Q insulin, providing that the patient is well looking, he can tolerate eating, he's hungry, he's not throwing up or he's miserable. If these elements are there, so we can switch to sub-Q insulin, and that's it. Any questions?